Good morning, everybody. We'll wait just a few more minutes here for other people to log on, and then we'll go ahead and get started. Thank you all for joining us this morning. We're going to go through a little bit of an update here regarding coronavirus and COVID-19. If you have any questions throughout, please use the chat mechanism to send those questions. And then I have a couple of wonderful people in the room here helping me moderate. So we'll do a presentation. Feel free to ask questions throughout the presentation. And also at the end, we'll leave as much time as we can for questions that may come up during the presentations or that you may want to ask afterwards. And just a few more housekeeping pieces here. If you're logged in as a group with multiple people, by the end of the presentation, if you can make sure you use the chat function to send us each person's name and email address, and also make sure the email that you've logged into Zoom with this morning is active and it's the one that you want us to use to make sure that we can get people their CE credits after this session. So we will go ahead and get started. So my name is Angela Wright. I'm an EMS physician here at the University of Colorado. This morning I'm joined by Danny Wilner, who's our EMS medical director here, and also by Mark Scherschel, who's our new EMS director. We're really excited to have Mark on board. We're glad that he's here, albeit a very weird time, I'm sure, to start a new job. We're going to discuss a few things today. We are going to go just a little bit over the background to get through some of the nuts and bolts of the virus. We'll go pretty quickly through that because I'm sure at this point you're all fairly familiar. We're going to go through a few of the other things that we don't know. We're going to talk about what we're doing about it here at the university and both in the EMS community and where we go from here. So what we do know, so a little bit of background, this virus, the novel coronavirus or the SARS-CoV-2 virus originated in the Wuhan province of China. That was where it was initially identified. And it's in the family of coronaviruses. It's called a novel coronavirus because it's novel to the human race. As far as we know, this has never been known to cause infection in humans prior to this outbreak. It traditionally causes a lower respiratory illness, and the severe illness that it's been causing is similar to an ARDS pattern. And SARS stands for severe acute respiratory syndrome, and then coronavirus too. Pardon my issue there. The symptoms, though, are variable, and we are finding there was a report that was just published by the WHO after a mission with China where they went through and basically studied all of the cases that they identified there to the best of their ability, and were able to get some numbers out of that study. And you can see on this slide, albeit a busy slide, that based on 55,000 laboratory confirmed cases, your typical signs and symptoms were fever, dry cough, and fatigue. And then from there, there's a variety of variability. So sputum production, shortness of breath, sore throat, headache, myalgias, chills, and then nausea, vomiting, and diarrhea in about 3 to 5% of patients. So there is a GI component of this, as well as nasal congestion, and then a few people with hemoptysis and conjunctival congestion. So it's typical in the sense that we think of a viral infection and a viral illness, but you can see based on the percentages here, while the most common symptoms are fever and dry cough, which is how we've been kind of running our testing, there is a fair amount of variability in other symptoms. There was also more data emerging about the inability to smell or taste as being a potential infection sign from this virus. How is it spread? So this is a hot topic, and especially for first responders, for people working on the front lines, like I imagine all of you here joining us are. It is a droplet spread virus. It is spread via respiratory droplets, coughing and sneezing, and those going out into the environment. Because they go out into the environment, they land on surfaces, which is what makes it contact spread, because if you contact the surface that it's on, that therefore makes it a contact spread. And then there's a lot of back and forth as to whether or not this virus is airborne. And that comes down to some of the aerosol generating procedures that we'll talk about. In the most pure definition of how this virus is spread, it is not an airborne virus in the way that we typically think of them. However, there have been some studies that have shown that it can live in the air after being expelled via a droplet or an aerosol generating procedure for around 3 hours. So while it's not purely airborne, it can live and hover in the air longer than perhaps we think of with other droplet viruses. But in its most traditional sense, it is not an airborne spread illness. One of the updates I wanted to talk about was that there's a fair amount of experimental treatments that have now been emerging globally for this virus. The first one is an antiviral treatment that is being studied by the NIH, and those are industry-sponsored studies, meaning they're being funded and paid for by the drug company themselves. This is an investigational antiviral that inhibits viral replication. The virus itself is a single-stranded RNA virus, and so the drug works to prevent the virus from being able to replicate itself. There are clinical trials that patients can be enrolled in order to get this drug if they're admitted to a hospital with an infection and with a COVID-19 infection. And it can also potentially be used in compassionate care. And what compassionate care use means is that we think it may work. It hasn't been studied, it hasn't been approved, but in a patient that's doing very, very poorly and we're willing to try whatever we can to get them better, that's what a compassionate care use is. And so it is available in some places for compassionate care use. The other thing you may have seen out there that's been heavily discussed is hydroxychloroquine and chloroquine, and these are oral medications. They're traditionally anti-malarial medications. There's a couple things that are definitely worth pointing out. These do cause significant prolongation of the QTC. And that's been known. Their toxicity is very, very well known, but in a otherwise very sick population, they can be higher risk medications because of that. And it has been looked at in a few very small, very underpowered studies to maybe decrease the viral load when they looked at the viral particles in a certain in vitro samples, but it didn't actually show any proven clinical benefit. So at this point, it's very much too new and unknown to say that this is definitely a recommended treatment. There are some other treatments that are out there that are being studied both through the NIH, both through the FDA, as well as in the compassionate care. So I anticipate as this continues and as we see more and more patients here with COVID-19, we will certainly be getting as much data as quickly as we can for different treatment options. But right now, the standard of care is supportive treatment, oxygen supplementation, and then early intubation and early proning in the ICU if it's a full ARDS reaction to the virus. So where are we now? We have community spread. We have community spread in Colorado and throughout the entire country. And there are new guidelines that are coming out as far as who we're testing, why we're testing only those people, and then if you do test positive or if you're sick, what are we doing with those folks? So as of right now, as of this morning, keep in mind this changes nearly every day, we are only testing people that are sick enough to be admitted to the hospital or healthcare workers. Essentially, those are the people that we're going to keep in the hospital, and we need to know whether or not they have the infection, or people that are working on the front lines. So most of the people logged in here. And otherwise, we have not expanded testing outside of that. There are occasionally tests for people that come into the hospital that are high risk, but that are not sick, that we test and send home. But the number of cases that we're doing that on is getting smaller and smaller. So the majority of the general public that have confirmed or suspected COVID-19 are not getting tested. That's why under test-based strategies is not recommended. And this is from the most recent HAN update from the Tri-County. And we recommend that if you don't know whether or not you're positive, but you start to have symptoms, at least 7 days after your symptoms start and your fever's resolved for 72 hours without any medications, and your symptoms are improving, you need to stay home. And then the CDPHE recommends at least a full 10 days after your symptom starts. Healthcare workers, as you all know, we are going to have a little bit of a different guideline, and some of that's because we need to regain the work, come back into the workforce, and some of that's also because we need to make sure that we're not risking our patients' health if we're back at work. So that's why healthcare workers are more aggressively tested. If they are tested positive, you have to have resolution of your fever without any fever-reducing medications and improvement in your symptoms and a follow-up negative result of an FDA swab, at least 2 consecutive swabs greater than 24 hours apart. So if you have a known positive test before you can return to work, those are the requirements. And again, this is per the Tri-County HAN. The guidelines are a little bit different depending on where you work and your institutional guidelines, but these are the most generic guidelines that we have, and I wanted to kind of reach the broader audience. And then similar to the non-test-based strategy for returning to work here is if you don't get tested but you have symptoms, it's the similar 7 days and 72 hours. And then hospitalized patients with confirmed COVID-19 also get the serial swabs to see if the virus is cleared from their system. The numbers are rapidly evolving. Everything is changing really quickly. More and more data that we get globally is going to help us calculate things, and testing again is very much the limiting factor on the situation. So the first box you see on the left of your screen there is from 3 days ago, and then the one on the right is from last night, the most updated situation report, and these are from the WHO. So you can see the numbers there. You can see the significant increase as we go through and as the number of cases and fatalities continue to climb. But if you look at some of the exponential graphs, some of the places in China, some of the regions in China that were hit very hard initially have already started to see a decline, and the number of new cases that they're reporting has decreased significantly. So there is an epidemiologic curve to this process, and it appears to follow traditional kind of epidemiology. And so I think we're on the upslope right now in the United States, but there will be a downslope on the other side. This is from the CDC. This is the state's reporting cases of COVID-19 to the CDC. So obviously take that all with a grain of salt. The state has to be testing and it has to be reporting. So the accuracy of these sorts of maps, you have to take that into consideration. And just kind of give you an idea globally or nationally where we're at. And here's the COVID-19 Colorado case summary. And this is updated daily from the CDPHE website. This is the one that was published at noon yesterday, so I anticipate it will continue to change. We have 1,430 cases, 184 of those are hospitalized. We've tested 10,000 people, and we've had 24 deaths. Outbreaks here are basically clusters that they've identified in a certain community that's at a residential place or a healthcare facility that's not a hospital. So 9 outbreaks as in long-term care facilities or SNFs or other places. And these numbers will likely continue to grow. Here's a graph that shows the cases of COVID-19 reported in Colorado by age group, hospitalization, and outcome. And our data here follows what we've seen globally, which is that the higher age groups certainly seem to have the higher mortality. You can see that dark blue part of this continues to increase the further along the x-axis you go, whereas the number of cases, number of fatalities from COVID-19 in the younger age groups is much, much smaller. And that 0 to 9 age group seems to be very protected. So what are we doing about it? We're gonna kind of start this part really quick with a case, and then we'll talk about some of the EMS specific things. So we have an 84-year-old female with a past medical history of CHF, and her family calls 911 because of increasing shortness of breath over the past few days. On EMS arrival, she's dyspneic, 3 to 5 word dyspnea, 3+ bilateral lower extremity pitting edema, crackles throughout her lungs. Her home 2 liters, she's has an oxygen saturation of 68%. So in the old world, before COVID-19, what would our next moves be? And I forgot this was going to be a chat-based interaction, so I guess I'll answer my own rhetorical question rather than crowd participation. But, you could attempt a non-rebreather, but putting her on positive pressure would be probably the next move in the field. And they all agree. That's perfect. Good job, guys. Strong work. You passed. Thanks. Or they passed. So what's different now? What's different now is you've probably all been getting messages from your medical direction that we're trying really hard to avoid aerosol generating procedures in the field and in the hospital in patients with suspected COVID-19. So in our 84-year-old patient that has known CHF but acute onset of shortness of breath, now it's nearly impossible to differentiate if that's from, especially in the field, if that's from a CHF exacerbation, if that's pulmonary edema, if it's volume overload, or if it's COVID-19 and ARDS. Early on in the course of this disease, you could do a good travel screening and do a good infectious history and talk about sick contacts to really try to suss out if this infection was on your differential. But at this point, with community spread as widespread as it really is, it's nearly impossible to figure out if this person was exposed to the virus and if that's something that's on the differential. So we're moving more and more towards avoiding the aerosol generating procedures in these patients, if at all possible. Now, you guys are clinicians and you are trusted in our community. And so if there's no other way to take care of this patient, or you feel that respiratory failure is absolutely impending, then you have to make the right decision. But what we want to emphasize from the EMS standpoint is that make sure if you are going to do one of these aerosol generating procedures, 1, that you're giving it a lot of thought, and 2, that you are wearing appropriate PPE. So why are these aerosol generating is a question. Why does the positive pressure and intubation and BVM, why are we so worried? And that goes back to how this virus is transmitted. So remember that it's a droplet virus. And as you know, when you put CPAP or BiPAP or you BVM somebody, the goal is to get a seal around their face, but that seal is never going to be perfect. There are always going to be gaps. There's always going to be areas for the particles to escape. And you now have high pressure airflow that's going in and potentially aerosolizing the virus itself and causing it to come out into your environment. If you do have to intubate somebody, if it's unavoidable, we recommend as best you can doing it in an open environment, in somebody's living room, outside, on the stretcher, not in the back of your ambulance if at all possible, because that's a very enclosed space. And the more open space you can get, the more you can get that virus to disseminate throughout the air and not be as much in contact with you. Nebulizers are another thing that are aerosol generating depending on the equipment you have, but they do fall into this category. Some of the nebulizers at the hospital have a trap valve, and some of the BVMs I know also have a HEPA filter. But it's not so much the air that's coming out, it's the forcing of air or that positive pressure into the airways that's disrupting the viral particles and causing them to flow into the air. And that's why we're so concerned about aerosol generating procedures. You may be asked, so depending on your protocols within your specific institution, sometimes if you're at a place where COVID is on your differential, you're very concerned about this patient, we encourage you to call your medical direction, talk it over with them, see if you can come to a conclusion together if you're uncomfortable. Otherwise, if you do make the decision to do an aerosol generating procedure, when you call to give the receiving facility a heads up, make sure that you mention that that's ongoing, and they don't be surprised if they ask you if it's possible to discontinue the CPAP prior to wheeling the patient through the emergency department. just be prepared to work collaboratively with the department that you're dropping off to figure out the safest way to get this patient inside so that we're not continuing to spread viral particles as we move the patient. So that might be disconnecting, that may be having the facility greet you outside with their own equipment. It's a moving target, and it's something that we're always working on and we'll need to get more creative with, but it's something that we want to make sure we emphasize. So where do we go from here? Here at the University of Colorado, we are working on a more streamlined notification system for pre-hospital providers. So we're working with our infectious disease folks and control to figure out a way to consistently and reliably let our pre-hospital providers know whether or not the patient that they brought in was COVID positive, so that we can alert them and make sure they were wearing appropriate PPE. Here at the university, we have ICU coordination and collaboration with multidisciplinary groups, surgical critical care, neurocritical care, anesthesiology, medical intensive care, that are forming basically COVID teams of critical care physicians that will be able to work collaboratively on the patients that are in the ICU or potentially ventilated. There are also procedure teams that are being developed, or COVID hot teams that will be working within the hospital to make sure that the appropriate PPE is donned and doffed when invasive and aerosol generating procedures are completed. We have metro and statewide discussions going on constantly about divert and EMS coordination and potentially the best ways to rotate patients through hospitals. Should we get to a point where every hospital is overloaded, what's the best way that we're going to try to coordinate EMS traffic? And those plans are all ongoing. There's also always conversations and meetings about potential alternate care facilities and what those will look like. Continuing to social distance and self-isolation. So in the WHO report, they really looked at the very, very aggressive measures that China took and tried to look specifically at the days that they started instituting their very aggressive measures and what that did to their epidemiologic curve. And it really, really did work. So one thing to say here is I know it's challenging interacting with friends and family and people that don't work as hard as you all do and that aren't on the front lines like you all are. But as someone who has recently had a few shifts, and Dr. Wilner in here with me too, it's here, it's real, and it's getting very serious very quickly. And I know that you all feel that, and I know that you all see that. So continue to encourage your family members. If people they're going to want to start to relax, they're going to want to start to think that maybe we've done enough or done the right thing, but we're just at the tip of this iceberg. And so continuing to encourage people to social distance and self-isolate if they have any symptoms is really, really important. And it's another part of our job as frontline providers. And then protect yourselves. Don't rush into a room, right? So this goes for those working in the ED, also those working in the field. We all are mission driven and we all want to take care of our patients, but you can't take care of your patients if you end up getting sick yourself. You saw those guidelines where you would have to stay home for possibly consecutive swabs. That takes you out of the workforce for a long time. So make sure that before you rush into a situation, even though it may be life-saving, you take the time to don the appropriate PPE. And if you put an N95 mask on at the beginning of your shift, at this point, it's recommended that you leave that on for as much as you can tolerate, because taking that on and off between patients and with your hands is one of the higher risk things that you can do. So protect yourself, use eye protection, use goggles, wear your N95 or the mask that you have been issued by your department for as long as you can tolerate. And as is always the case in EMS, check your own pulse before you check your patients and make sure you're taking a big deep breath before you walk in, and don't rush in and put yourself at risk, potentially harming yourself and your family. There's some sources there. The majority of the numbers and the data from today are all from CDPHE, CDC, and WHO. I highly encourage kind of clicking around in those websites and seeing what you can find. Specifically, the WHO did publish that report. If you're interested in virology and kind of epidemiology, it's a very interesting report to go through and to kind of learn more about this virus itself. We can kind of open it up now for Q&A.
So I'm going to read through some questions that we got. If people have other questions, please type them in. We're happy to answer them as best as we can. Have answers for everything. We'll try to share resources where you can go look it up yourself if we don't have a specific answer. We got a question on UV lights for disinfection for children.
So all of the data for that is coming out of Nebraska, the University of Nebraska, and I can, if we can put down who asked that question, I'm happy to send out an email with the study. They did a study at the University of Nebraska looking at this, and they showed that it was in fact an effective way to disinfect N95s and other PPE. It was an underpowered study like all of our studies are right now, but it was safe, and it did show that it maintained the integrity of the mask throughout the disinfecting process. So we're, I think, trying to gather our own data here at the University of Colorado right now, but the model is off of the University of Nebraska for the UV disinfecting strategy. But at this time, it really does seem to be effective. As far as like home UV lights, I know there's a lot of conversation out there about should we get a UV light at home that you could put your stethoscope under or something else under. Honestly, use the purple wipes. They're much more effective, and I don't know enough, and there's so many different grades of lighting that I think it's probably not a super reliable home method right now, but the hospital degree of it does seem to work.
Yeah, I think this is Dr. Wilner. I think the thing that I would emphasize is if your agency already has it, it's something you can consider using. I think probably the time to purchase it, the cost of purchasing is going to be sort of a limiting factor for most agencies at this time, and we're not currently using it to any significant extent at UCH. Next question for you is, are hospitals and healthcare systems considering DNR orders for patients who are admitted with COVID?
Yeah, there are ongoing conversations, especially through the ICU levels, about whether or not we implement essentially a unilateral DNR, which means that rather than the conversation with multiple signatures, it's one person making that decision. Certainly other parts of the country have instituted that, and we're having the conversations here. That's not something that I see extending to the pre-hospital realm. Obviously, it will be something that will be done on the hospital side, but it is something that it should be run out of ventilators or run out of critical care capabilities is something that we would have to consider. All of those conversations, there's a whole body of literature and data on something called crisis standards of care. And if you go to the Tracy website, and you know what I'll do after this, when we have everybody's emails for CE, is I'll send everybody out an email with some of the kind of top resources for some of this data. But the Ask for Tracy website has a whole section on crisis standards of care, which is basically where we start to change our normal day-to-day care in medicine to try to adapt from a resource rationing standpoint.
Yeah, and I emphasize that it's not across the board DNR or for anyone who gets admitted. There are ethics teams that are heavily involved in making those decisions in conjunction with the ICU teams based on if we reach a crisis standard of care for patients. It's not how we would do the day-to-day operations. The next question is for patients who are diagnosed with COVID but are homeless and aren't sick enough for hospitalization. There's a specific plan for those patients.
There is not a specific plan right now, but that certainly is one of our highest risk group of patients where because of oftentimes the crowding of the shelters and the close interaction, what we're seeing is outbreaks potentially within that community. I will say, and this is completely anecdotally, this is my own personal opinion, but the patients that I have seen that are diagnosed with COVID that are homeless have been super sick. Very, very few of them, because there are so many underlying comorbidities in this patient population. Very few of them have actually been. And again, this is anecdotal. I don't know, Dr. Wilmer, if you have seen the same, but I pushed for admission on a lot of these patients for this exact reason.
Yeah, that's exactly right. Because we know that a patient who ends up going to a shelter or going and being around multiple people is just going to end up infecting all of those other people. So it's actually, from a public health standpoint, probably a better use of resources to hold on to that single patient as opposed to potentially having 10 additional patients come in a week's time. The next question is, if local ICUs are overwhelmed, is there a plan for setting up field hospitals or remote ICUs?
Yes, essentially the ICU structure is what is best obviously utilized within the hospital, and the hospital infrastructure is the best place for critical care. So the alternate care facilities would more than likely be used to try to offload the not sick enough for the ICU cohorts of patients that still needed to be hospitalized, because the mechanics of caring for those patients is so much easier. And then hopefully being able to flex and grow within each own institution to expand the availability for critical care within the institution. Now, depending on how potentially big this gets, the military function and some of the other things that they can set up and establish may include off-site critical care units. But as of this point, the off-site areas would try to be for patients that weren't sick enough for critical care, but still needed care, and then we could use the hospital infrastructure for the critical care.
We work closely with the other hospitals in the area through the North Central region health department to develop options for offsite care. So those already exist. And when they wanted to have the decision at a higher level, either at the regional level, in conjunction with several hospital systems, based on overall volumes and but there are ways to flex if our local resources are strained or overrun in terms of certifications. The next question asks about sort of PPE and protecting the ambulance, about putting plastic up either around the entire back of the ambulance, protecting the entire patient compartment, or just in the pass-through between sort of the front driver compartment and the patient compartment. If there are recommendations or studies or any sort of best practices.
The ideal situation is an already blocked off driver compartment, which I know is not the case in the majority of the rigs, especially in the Denver metro area. As far as kind of makeshifting the plastic coverings, I think that any physical barrier is probably beneficial, especially if there is an aerosol generating procedure going on in the back. However, having the back and front compartments connected does allow for a better potentially makeshifted negative airflow situation. So you can blast the air from the front and open the windows from the back. I don't know, Mark, if you can help with that question a little bit.
Yeah, I think the plastic is better for aerosolized generating or any wet patient that we see. Thinking about things like Ebola. Cordoning off the driver compartment obviously makes sense for any patients when cross-contamination is an issue. The things to keep in mind, in my opinion, when either you do or don't have that kind of barrier is, simple things like avoiding the aerosolizing of any contaminated patient. Keep your cabinet doors closed so that if you are going to aerosolize, you're not, making a bigger problem by contaminating any of your equipment that you're going to use on a future patient. And then wiping things down. Aeroclaves are wonderful. UV lights were brought up a minute ago, and those may or may not help. The aeroclaves for the agencies that have them or have access to them can really help, I think, to diminish the what's in the back of the ambulance. So if you need information on that, I'll have Angie send out my email, and we can get that out, and perhaps the NCR can work on getting aeroclaves to agencies or having kind of a network that can share during this time. There was a grant that closed a couple of weeks ago to get aeroclaves for agencies and for hospitals, but that grant is closed, unfortunately. So I'll include my new contact information at the end of this.
So the next question is, are there any studies that show ibuprofen or other over-the-counter NSAIDs should be avoided? This is a tough one. So there is an area where a study that's been looking at why some people do really poorly with the viral infection and why some people don't. And it's thought to be secondary to the way that the virus interacts with the ACE receptor within the body, specifically ACE2. And NSAIDs traditionally act by interacting similarly and potentially upregulating. So if you have more of that ACE receptor, there was initially a thought that maybe you would do worse if you got infected with the virus. And that was then extrapolated to say, well, maybe NSAIDs and ibuprofen have the potential to upregulate that virus. I talked about this with one of the toxicologists, Dr. Janetta Iwanicki at Denver Health, and she and I had a little bit of a discussion, and in her opinion, in the Rocky Mountain Poison Center, obviously they don't have a formal statement on this, but 1 or 2 doses of ibuprofen is not going to be a big deal. We don't think that that's enough to really make a big difference one way or another with this virus. Certainly taking 600 of ibuprofen Q6 hours for weeks has its own consequences in many ways, but potentially that's where we could see an upregulation of this receptor and worsening outcomes with the virus. There's not enough data to say one way or another, but at this point the recommendation is mostly to stick with Tylenol, stick with acetaminophen, and basically PRN ibuprofen, but it should be maybe second line until we know more. The next question is, are we seeing high-grade fever, low-grade fevers as patient become more symptomatic? It's a multi-part question. I'll just tackle that initially. So it's all over the map. It's very interesting. Some of it is low-grade, some of it is high-grade. What we are starting to see is, for some reason, in the early afternoon, there's kind of a cyclical pattern to the fevers, almost like you would think of with malaria, kind of a waxing and waning. And so the question is, the answer is super vague, which is some of the patients that we've admitted are completely afebrile. Some of the patients have been upwards of 40 and 41 degrees. So the fever, the WHO and CDC changed the definition of fever for this particular virus when discussing as 100.0 instead of 100.4 to kind of try to bring in those lower grade patients. And then the questions are the GI symptoms specific to diarrhea? Are we asking them about specific GI complaints or descriptors? Certainly not specific to diarrhea, nausea, vomiting, other GI symptoms are associated with this. And the screening questions, the GI symptoms seem to be coming a little bit later on. Even abdominal pain is kind of have a high index of suspicion for that. So yes, it should be part of your history taking. It should be part, and you should have a high index of suspicion if a patient is talking about having diarrhea, abdominal pain, or GI complaints. Okay, so I'm scrolling through some questions here. Question from Miguel: if someone is a carrier but not showing symptoms, how long are they considered a risk to others? Really, yeah, this is a good question, and this was addressed a little bit in that WHO report. So they actually found that the number of people, so in China, what they did, just to give a little bit of background, is they had 18,000 teams of contact trackers, and each of those teams had 5 people on it. And they went through with their outbreak almost every single person that was diagnosed and traced their contacts as a way to try to study this virus. It was an incredible effort. And what they found as far as the asymptomatic carriers is traditionally the people that had no symptoms had a very, very low transmission risk to the people that they were around. And this is the data out of China, but essentially, unless you were symptomatic, you had a very low ability to spread the virus to somebody else. There were people that were tested that had a high viral load, but if they weren't coughing, sneezing, febrile, having diarrhea, etc., they weren't transmitting the virus to other people. And then if someone recovers from COVID signs and symptoms, are they more susceptible to becoming sick again? The hope is obviously the opposite. We are just in the beginning stages of being able to see what the recovered population is kind of capable of and what it's going to look like. So the true answer is we don't know yet, because the full recovery for patients that are hospitalized from COVID is on the side of 3 to 6 weeks. Patients that are not hospitalized typically recover within 1 to 2 weeks. And so we don't know yet kind of what those patients are if they're gonna be able to get sick again. We haven't seen a second peak in some of the areas of China. And so that would imply, now some of that's because they locked down and are not, have flattened their curve so significantly, but some of that would also imply that even within their families, they're not reinfecting one another. And we also don't know how long you potentially would have immunity from the virus if you do contract it. Next question is, if we experience shortage of nurses, is UC Health planning to utilize nurses residing in Colorado without state licenses if they're willing to volunteer? It's a very good question. I do not know what the policies and procedures are going to be as far as calling folks from the community, and I think the university leadership, I'm sure, are working through to figure out if that's going to be something they'll consider. We're working on some sound difficulties. Okay, that's all the questions that we have on the chat right now. Oh, new question from Janelle. Have we tracked a certain blood type that is less susceptible? Not that I am aware of, Dr. Limmer. He's shaking his head and shrugging, or shaking his head. We don't know, is the short answer to that. But speaking of blood, Janelle, I'm glad you brought that up. There is a significant statewide, nationwide, honestly, but specifically statewide blood shortage as well. I don't know if y'all have been seeing that in the media. The reason for that is the majority of our blood drives are employee and community based, and with social distancing, you're not going to get a bunch of people together and draw blood. So if you have the ability to do so and the desire to do so, please contact your local blood bank. And as you guys are all doing enough, you do not need to go donate blood. You're doing enough. But anyway, just a plug for blood because we're going to need it. What's the long-term expectation of how long COVID will last? Is this the new norm? I think this is the new norm for a while. We are, like I mentioned, at the very beginning of this, and I anticipate on the order of a couple months at least of practicing kind of in this new environment. Obviously, every day that goes by, we learn more and more, and we will know over the next, we'll say 4-ish weeks, if the social distancing and stay-at-home orders were enough to flatten our curve. But if you flatten the curve, you kind of extend the duration a little bit because you are not overloading the healthcare system. And so the number of people getting infected at one time is decreased, but it still kind of lingers a bit. I think this is the new norm for at least the future that I can see right now. Dr. Bowman.
Hopefully you guys can hear me a little better now. One thing that I think is important to emphasize is that when we talk about flattening the curve, we can't say that that's going to happen across the country all at the same time, because each of these regions are pretty separate. New York's curve is going to be happening at a different time potentially than New Orleans and here. And so the reality is, it's not like the entire country is going to happen all at once, all at the same pace, which is one of the things that makes it so challenging to predict how long this will last. But I think that we need to sort of look at regional areas of the country when we think about sort of expected time frame, just because of the realities of how transmission has occurred and the fact that we don't see cases present until 5 to 10 to 14 days after the initial infection, right? So there is that delay, that period where people are, infected but not yet symptomatic, where we don't have good information because they're not being tested. So I think that Dr. Wright's right on point when she says that this could be going on for, at least several more weeks, if not a couple of months, unfortunately.
What other questions? I'm sure there's a lot out there. Like I mentioned, we'll make sure that we send out an email for people that participated today, and feel free to obviously pass along with different resources and places that you can go as things evolve. I think that it's like I said, constantly moving target, and I think that using reliable data is really important as frontline providers to make sure that we're communicating effectively with our community and being leaders within our community. And then if you have any other questions, and do you want them to email that for? Yeah, for everything. Desmond McNeil is our EMS coordinator here at the university. His email is desmond.mcneil@uchealth.org. I will spell that for you. It's DESMOND as in dog, sorry. Danny's trying to type it as I'm trying to read it. .McNeil. He's sending it out on the chat. Thank you, Desmond. At uchealth.org. Please just email Desmond with your questions. I'm learning this whole technology thing clearly, and we will continue to answer your questions as best we can. I'll send you those resources. I really appreciate all of you being here today too and taking the time to listen.
One other thing that I want to add, and this is still in the development phase, is that, so I don't have a time frame for this, is that UC Health is hoping to be able to provide testing for not just our healthcare workers, but also external healthcare workers, i.e. EMS providers, firefighters, police officers across the Front Range. Again, this is still in the works, but we're working to find ways to try to get you guys the testing you need so that you can feel comfortable going to your families and comfortable going back to work if you're symptomatic, right? We have just instituted in-house testing here at UCH, which has dramatically improved the turnaround time from what was days to even a week, utilizing CDPHE resources just because of how limited they can do it, to a matter of hours for patients. Like I worked literally overnight and I already have a result on a patient that I took care of. So I think that that's something that we're all hoping for across the board, across the spectrum at all healthcare facilities and at the state level. But I think that we are just now ramping up capabilities in large part because we needed clearance from the FDA to start doing it internally. And it's potentially going to be a game changer in terms of our ability to test in mass, in large scale, and also maybe an opportunity open to you guys. So more to come on that, but hopefully we'll have more information soon.
And then just a few other housekeeping things and plugs at the end. I think one question that certainly is lingering out there a lot and that I had is as far as the pediatric community. And I do know that Children's Hospital is working very hard to make sure that they have coordinated efforts across the group. The kids that do get infected with COVID do very, very well. There was a study that was published in Pediatrics of about 2,400 patients under the age of, I believe it was 16, that were COVID positive. And of the 2,400, there was one fatality. And that group of patients, I think 6% of them were considered severe to critical. So kids are doing very, very well. And the WHO report out of China also demonstrated that for some reason, if the only person infected in a household was a kid, they didn't seem to spread the infection to the adults in the house as significantly as adults spread it to adults. So a lot of research coming out of that realm, but for those of you with families and small children, I think it's okay to feel a little bit better about how this certainly seems to be protected somewhat our pediatric population. And then another question, isn't testing the best surveillance tool? Why was South Korea able to test so rapidly and we seem so far behind? It's good. It's a great question. It's a great surveillance tool, Dr. Wellner.
Yeah, certainly. I mean, very early on in a pandemic, if you can test widely, then you can isolate individuals who are identified as positive and potentially break the cycle. We unfortunately in the United States sort of missed the boat on that and are sort of at the point now with community spread where source tracking is almost impossible with the number of cases that we have. So in the ideal scenario, I think there would have been widespread testing. I think there's lots of thoughts on why that might be that it didn't happen, whether it's a regulatory issue, an oversight issue, or whatever else it might be. A lot of the issues we ran into recently have dealt with viral media and reagent, and actually in order to actually run the test, which you need specific sort of types of media, swabs, and reagent to actually perform the test. And so that was sort of the choke point for many regions. The other issue was just that there weren't enough machines to run the number of tests that we needed to do. So obviously lots of potential reasons why that might be. I think that's sort of beyond the purview of what we're discussing today. But at this point, we're at the moment sort of outside of that widespread testing phase. We may get things back under control and move back towards widespread testing, but that remains to be seen.
Right. And then a last plug, because I promised our residents I would mention it. We have two residents, both were paramedics in their past life, Matt Mendez and Ross Orpet, that are currently Denver Health Emergency Medicine residents, and they started an EMS podcast. EMS Cast, I believe is how you can find it, and I will send out the link. They've been doing sessions with people throughout the Denver Health and Denver metro area and UC Health and EMS community. And so keep an eye out for that. It's a really cool resource, and we're trying to support our residents. I know they put a lot of work into it, and so I'll add that to the list of things at the end. Thank you all so much for being here today and for asking your questions.